Adrian, thank you so much for joining me for a Corona conversation. For people who don't know you, can you maybe introduce yourself, tell us where you are and what you do for a job?
Sure. Hi, Adam. My name is Adrian Dunlop. So I'm an addiction medicine specialist based in Newcastle, which is a regional city in New South Wales, Australia. So my principal job is as a clinician, but I'm also the director of that service. I'm involved in how the service runs. It serves about 920,000 people over an area 2/3 the size of Germany. So it's a big rural area, and also do some research there.
Fantastic. So this is all around the impact of coronavirus on people who use drugs and alcohol. So maybe if you can start off, maybe actually just telling us what's the state of play of COVID-19 in Australia now?
Sure. Look, so it's clearly escalating day after day. At the moment, I think the median doubling time is about 3.6 days in Australia. That's too quick. There's some public health measures to try to slow that down, but I don't know if they're going to be effective enough. So we might see some of the rates of increase in cases that you're seeing in Europe at the moment. I hope not, but I think that's possible.
Okay. And as far as you know, has there been any impact on people who use drugs and alcohol so far?
Look, the stuff I have, is not very detailed. Some patients in some areas are saying, yeah, drugs are getting harder to come by, but it's not across the board enough to really be able to say that confidently yet.
Okay. And how about when it comes to kind of drinking, either among your patients or even just what you're hearing on the grapevine? I mean, I read stuff that alcohol purchases had gone up by 20 to 40% in some parts of Australia.
Yeah, so unfortunately, there's all sorts of crazy panic behaviour, and I think in a situation like this, you sort of see both ends of the spectrum. People typically initially underreact and sort of think, "Oh no, it's not going to affect me. It's it's a hype, it's a beat up," or they do the reverse. They just absolutely panic and go into a state of anxiety and do all sorts of crazy things like buying all the toilet paper in the supermarket or whatever. So there, at some stage there was some talk that the bottle shops were going to shut, and it wasn't an official media release or anything. There was just chatter about it, and then all of a sudden people were panic buying alcohol. So, unfortunately that's how humans respond. They respond, they under respond or over respond, and it's hard to know what the appropriate response is to this situation.
Finding the sweet spot is difficult. Yeah. So the rumor we heard that they thought about shutting the bottle shops, but then it was decided that bottle shop for essential services in Australia isn't necessarily true.
It's not quite like that. One of the states, WA, has implemented some restrictions on the amount of alcohol that can be purchased, and their rationale was to decrease police call-outs to, violence. The threshold's pretty high, so it still will have an impact because, of course, there are the people, the small group of people who drink the most drink a hell of a lot of alcohol. So it will have some impact, and maybe it will have some public health benefits. Hard to know, but it won't affect the average person who's a drinker.
Okay, so one of the things that we've heard from other countries we've spoken to is that services are trying to reduce the congregation of people in services when it comes to pickup, and they're starting to increase the number of unsupervised doses. I'm just wondering what, from an opioid substitution treatment perspective, you've done to try and offset any of the potential issues that come with physical closeness when people are picking up medications and attending clinic.
Yeah, sure. So certainly the Australian approach to opiate treatment is largely based on supervised dosing, both of methadone and buprenorphine, as buprenorphine naloxone. And it's really only some people who get to progress beyond that starting state of being on supervised dosing. So COVID-19's really flipped this. Well, it means we have to flip that thinking on its head and think a lot more from a public health perspective rather than just an individual clinical perspective. And that's a real challenge for clinicians in many areas, I think. It's hard in the public health system where we've got colleagues we can talk to and bounce these ideas around. Of course, something like 80% of the treatment in Australia is with GPs and community pharmacies, so it's going to be even harder to get the message out there. But very clearly, there's modelling that shows you need 70, 80, maybe 90% effectiveness of social distancing. And you can't have that when you've got 100 patients coming into a clinic each day, queuing up, usually in close contact with each other, spending a lot of time with each other. That's not going to work. So we've really got to flip that on its head and think, why do we really need to have people coming in very regularly, and everybody else we should be having coming in as infrequently as possible? So we're in the process of doing that now for 900 patients approximately. It's a very significant undertaking. We're, some way into it. I don't think we're yet, but we're some way into it, and it depends a lot about the local logistics too, what you've got, what services you've got, how many community pharmacies you've got, what dosing services you've got. We've tried to split our services, so not all the services happen from one site. So if we've got depot buprenorphine injections, for example, they happen at a different site. We're splitting the clinical team, so we've got backup clinical teams. So if there's a contact in team A and we've got to isolate that team, team B can step into team A's spot, and somebody another team can fill in behind them. But a lot of this we have to do very much on the run. It's a group discussion each morning, working out what the next things we should be doing for that day, and then we move on through the day, and by the end of the day typically we get the numbers of new diagnoses the previous day, so we're always 24 hours behind. And of course, in terms of the measures, the public health measures, they're really, it's a 2-week lag to see what the benefits of those are. So we are still behind the game, and the projected number of cases is going to increase quite significantly before and then after Easter.
So you're the first person who's mentioned the idea of splitting clinical teams to isolate any breakout. I mean, that sounds like a great idea that other services could learn from. Yep. So you're saying that you're looking at flipping things on its head. Do you envisage you're going to be getting to a point where the majority of your patients are going to be getting weekly takeaways, for example?
I think we're going to, to use that sort of rough sort of rule of you need, really upwards of 70%, the more the better. To decrease distancing. I mean, clearly it's patients or people's behaviour across the day, not just at the encounter with dosing, but really we've got to look at having a target of something like only 10 or 20% of people coming in on any sort of regular basis, and everybody else not doing that, which is not how we've operated as service. So it's very. So
is that going to mean people walking away with a litre of methadone?
1 week, 2 week, 3 week, 4 week. Certainly with Suboxone, that's not that challenging. With methadone, it's harder to do, but that's the sort of thinking we're going through at the moment. And clearly, a very important part of it is ensuring people have naloxone. So we've got the nasal spray and in pre-prepared injection here, and they're the two main sorts of naloxone that are being given out, but making sure that patients walk away with those as well as takeaway doses. There's some problems with supply, so we're waiting for more supply, but we've got to get this changing now, not waiting for weeks and weeks for it to happen.
And obviously, if people are walking away with a litre of methadone, it's then ensuring that there's a place for safe storage and that doesn't go leaking.
And there's all sorts of safety and other issues related to that, so they're challenging discussions to have.
So a couple of people I've spoken to have said that they think that COVID may fundamentally change the way we deliver treatment. So the idea that we have services that run to suit providers, that we have a very paternalistic view, which comes from a place of not wanting lots of methadone in the community because we know that's linked to overdose. But certainly user groups I've spoken to have said, this is the opportunity for people in treatment to show they can be responsible, and to show people who are delivering drug treatment that treatment can be delivered in a way that is more acceptable, more humane, and more respectful. And I'm just wondering what you think treatment services might look like in a year from now. Do you think things are going to have changed because of our experience?
I think my guess is that almost certainly things will change, and they'll probably change pretty significantly, but exactly how, I really don't know, Adam. It's just way too early to tell. I think once you change to a new system, it forces you to think, so what were the benefits, and why did we think our previous system was such a good system? Maybe it's possible if there's evidence, environmental evidence elsewhere, that if you increase the number of methadone takeaways, you get more methadone overdoses. We haven't had a natural experiment quite like this before, so it'll be important to see if that does happen. It might not get much limelight. If you've got many people dying from COVID-19, it might not get much limelight, but still avoidable deaths. It's better avoided. But these are the sort of individual public health versus individual clinical situation sort of thinking we've got to do now, and we've got to do very rapidly. So I think it'll change, but it's my guess of where it'll land.
But you're right. It's that so many of us are going to have to undo things that we've just taken as gospel for the last 15, 20 years. And that's difficult when we've all been very confident why we've done these things, and we have research and we have evidence and we have committee meetings and guidelines, and it's like, oh, we didn't have to do it like that. It's going to be a strange time.
Absolutely.
Are you getting more people coming into treatment in response to concerns that the illicit drug supply is going to dry up?
Not large numbers yet, but I expect that could happen, and we're trying to make it possible so if people are presenting to treatment, they can access it quickly.
So one of the other things that I think is fairly unique about your situation, as you said, it's an enormous geographical area. How are services going to adapt for people in remote and rural areas to be able to get treatment out to them? Are you going to be using telehealth? Are you looking at methadone delivery buses? How are you going to kind of ensure people get continued safe access to treatment?
Yeah, sure. So we already were using telehealth, but this has ramped it up to another level for sure. In terms of non-opiate treatment, we haven't talked much about that, but pretty much all non-opiate treatment, we're saying let's switch that to telephone or telehealth. So that's happening now as we speak. That's clearly very useful in us giving back up to the smaller rural centres. Moree, for example, I'd visit once a month. I'm not visiting there once a month now, but I'm talking to clinicians there very frequently. And we can do video conferencing at very short notice. The issue of dosing is a very challenging one, especially when you get to more rural areas. My guess is there's going to be a bunch of situations where we have to treat people with buprenorphine, because that's the only feasible treatment there is, and that'll mean certainly transferring patients from sublingual, but also moving some people over from methadone. We've started to do that. We've been offering that to patients if they want that now, given the sort of current situation, saying if you want us try to move you quickly to methadone, we'll do it.
Okay. So one of the other things I think differentiates Australia from much of Europe is the most common drug used in conjunction with heroin isn't crack cocaine, it's crystal meth. Are there particular issues that people should be aware of clinically when it comes to crystal meth and COVID?
So there's some evidence that methamphetamine use in the long term might be associated with pulmonary hypertension, and pulmonary hypertension or any sort of chronic lung disease puts you at increased risk of contracting COVID-19. But there are other very common problems like regular tobacco smoking or cannabis smoking, very common in our patients. Certainly put you at increased risk. Hypertension, a bunch of other organic problems put you at increased risk. So many of our patients have got multiple risk factors. And all the more reason that we should be thinking along, not just doing treatment how we used to do it, but how we're going to try to best help these patients protect themselves.
So the final thing I want to ask about is that some of the places I've spoken to, like in Brazil or South Africa, where treatment is really sparse, the people I've spoken to have said, things were in crisis beforehand. Issues of homelessness, poverty, they're the things that really make life almost impossible. Parts of Australia do have a homeless population, and I'm just wondering whether or not there's been a particular emphasis on getting people housing and secure food, just those basics.
I wish I could say yes, Adam, but no, not that I'm aware of, not on any significant scale. It's something that clearly needs to happen, and people are homeless at very high risk.
Okay.
But,
so finally, Adrian, you're probably 2 or 3 weeks behind where Europe is, and hopefully the things that you're putting in place will slow things down. When you look at what's happened elsewhere, what are kind of the 2 or 3 lessons that you hope your government and policy advisors will take on board so Australia doesn't end up in the same situation as Italy or Spain, for example?
I think, just generally having a clear and coordinated response and giving consistent public health messages is something that has improved, but it could improve a lot more. I think there's been really mixed and confusing messages that have gone out to the Australian public. That's a problem. In the drug and alcohol area, very particularly, it's, we've got 50,000 patients in treatment on methadone and buprenorphine. That treatment shouldn't put them at increased risk of COVID-19, ideally. So that's something that's got to change, but changing that very quickly for 50,000 people, for clinicians who have been practicing the same way for decades and decades, ain't an easy undertaking. But if there's one thing that I hope for, I hope we can use this opportunity to do that.
Yeah. And have you found links with peer using communities and peer organisations? Have they been working well?
I think they have. I'm certainly aware of some information New has put out, a bunch of different stuff actually New has put out. I'm less familiar with what's happening in different states in Australia, but very necessary. I've seen some stuff from Industry Today, also very helpful. So yeah, there's connections, but of course they could be better.
Okay. Listen, Adrian, thank you so much for taking us through where things are now. Because this isn't a problem that's going to go away very soon, my guess is I might want to come back in a month or so and see where you are, and hope that all the things that you've spoken about putting in place are in place, that clinicians have ripped up stuff they've done for 20 years, and yeah, everyone gets through this as well as they can. So I really appreciate it.
I hope so too.
All right, mate.
And so the question that you chose to ask, will it be better where we're going? And though the answer I don't know for a fact, still my heart is saying, oh yeah.
Still just taking it one day at a time. Still don't know what I'm trying to find. Really I don't mind, cause I'll be fine. Yeah, I'll be fine.